going to discuss two scenarios. One is regarding the acute pancreatitis. Second one briefly about the intragastric balloon. And this is case. This case is about a 14 years female girl. Mainly, she came to us with recurrent episodes of pain abdomen, and each time outside, by the time she presented to us, she had 4 episodes of discrete episodes of pain abdomen, and each time she was diagnosed outside as acute pancreatitis, and each one, fortunately, were mild in nature, uh, and all of them managed conservatively outside. And at this time, now on the 5th episode, she came to us with pain abdomen of 3 days duration, which is a classically located epigastric and the region, and there were no any signs of organ failure in the history also. And considering the past history, except these previous episodes of acute pain abdomen, there was nothing contributory. And on physical examination, our vitals were stable, and systemic examination also, except for the mild tenderness, the rest of the all are normal. Investigation wise, she has a mild anemia was there, and rest of the lab parameters were normal. Hydatid serology we repeated twice. Both times it was negative. Amoebic serology was negative, and we rule out the other causes of the recurrent episodes of the pancreatitis, like hyperparathyroidism, and IPTH levels were normal. Stool examination, we did stool examination to rule out worm infestation. It was normal. She had vitamin D3 deficiency. Coming to radiology, this is a chest X-ray of the patient, which was on both lung parenchyma was normal. There was no effusion. This is the earlier CECT abdomen before the earlier presentation, one of the earlier presentation. Here you can see the axial sections of computed tomography of the abdomen. Here you can see the right lobe of the abdomen. There is a cystic lesion in the right lobe of the liver. There is one speck of calcification in the wall of the cystic lesion you can notice. In other sections, similarly you can notice the elongated longitudinal cystic lesion in the pancreatic parenchyma occupying the body and the tail lesion, and along with the prominent duct or pancreatic duct in the head of the pancreas. If you closely observe, you can notice fine septations in between the cystic in the cystic. Now we repeated the CCT abdomen during this episode. Similarly, these axial sections here you can see the similar cystic lesions in the right lobe of the liver, and elongated longitudinal cystic lesion along the body and the tail region. And here you can see in the body and the head region the prominent pancreatic duct, which is probably communicating with the main cyst, pancreatic cystic lesion. And this is here you can see head of the pancreas is bulky with mild peripancreatic fat standing as notice, which is suggestive of the acute pancreatitis. Considering the cystic lesions in the both and the liver and the pancreas, we thought it could be hydatid cyst, and there is obvious cystic neoplasm, and we consider the cystic neoplasm of the pancreas also. But one other thing is, because of the both liver and pancreas involved with cystic lesion, we consider hydatid cyst in this case. Subsequently, I did endoscopic ultrasound in this patient. On endoscopic ultrasound, we noticed a small, very few hypoechoic, well-defined cystic lesions within the large cyst. These are the small cysts located in the large cyst. This is the large cyst wall. Here you can notice very clearly there is a small hypoechoic, well-defined cystic lesions. This is a large cystic. This is a dilated pancreatic duct with debris. This is a dilated main pancreatic duct with debris. You can see. This is a cyst wall containing the multiple hypoechoic cystic lesions. And this is a communication. This is a we could observe the communication between the pancreatic cyst, and we could demonstrate communication between the pancreatic cyst and the main pancreatic duct, which suggests fistulization. After doing the endoscopic ultrasound, we thought most likely it could be the some pancreatic cyst lesion communicating with the main pancreatic duct. And however, there was a communication we could demonstrate on the EUS ERCP in this patient. We did routinely with adult scope only. We did the ERCP. We attempted ERCP and pancreaticogram. Here you can see there is a opacive, dilated main pancreatic duct in the head region. And it is directly contrast is going into the cyst cavity. Within the cyst cavity, you can see the multiple filling defects within the cyst cavity. There was no opacification of the pancreatic duct in the distal body and the tail region. Subsequently, we did the sphincterotomy and we did the balloon dilation with CRE balloon, and we attempted pancreatoscopy also. While attempting the pancreatoscopy, and we could see the whitish discharge and the remnants of white membranes coming out of the papilla. After that, we stopped doing the pancreatoscopy and we attempted balloon trial. And by doing balloon trial, we extracted many whitish membrane and cyst walls like this. And subsequently, we sent it for the histopathology also, which is consistent with the hydatid membranes. Subsequently, we placed the pancreatic duct stent within the cyst wall. We repeated the procedure 2 times after giving the gap of 3 weeks, along with medical therapy. And to summarize, this patient came with recurrent episodes of the pancreatitis, and subsequently we confirmed the diagnosis with the US and CSG imaging, and we treated with ERCP and the pancreatic stenting along with medical therapy. She responded to completely the treatment. Now she is symptom free. Our unit's final diagnosis was hydatid cyst as a reason as a cause of recurrent pancreatitis. And I am going to discuss how hydatid disease can cause the pancreatitis. Our points of interest is what is the role of endotherapy, like in this case, and how it can cause hydatid disease can cause the pancreatitis. As we all know, the hydatid is a known zoonotic disease in which is mainly caused by Echinococcus granulosus and multilocularis. In both of these, humans acts as an intermediate host. Dog is a definitive host. Here you can see the sheep. Mainly, man is an accidental intermediate host. As such, the definitive host is a dog, and the intermediate host is sheep and goats. The embryonated eggs in the feces are the infective forms. As we know, it contains a 3 wall, that is a pericyst, exocyst, and endocyst. Within the cyst, you can observe the many daughter cysts. If you consider the location, the pancreas is a very rare. It is a less than 1% the total number of the cases. Liver is the most common. Lung is the second most common. Even though it can affect any organ in the body, the most common set is the liver. Pancreas is very less and contributing to less than 1% of cases. The most of the cases, this is the solitary lesions and very slow growing, that is less than 2 centimeters per year. It is the most common site. How it reaches the pancreas after ingestion, how it reaches the pancreas. There are the various routes like hematogenous and biliary system or lymphatic channels that I am going to explain. These are the embryonated eggs. These embryonated eggs are the infective forms. Once you ingest, it reaches the stomach, and from there it goes to portal circulation, and it reaches the liver. Liver acts as a first filter for these infected forms. That's why the liver is the most common site for the hydatid cyst in the whole body. Once from the liver, it can reach through the hepatic veins. It can go to the right side of the heart and reach the lungs. Lungs acts as a second filter for this cyst. That's why it is the second most common. From there, it can go to the left side of the heart, and from there to systemic circulation. Once it reaches the systemic circulation, it can go to the any organ in the body. Like it can come to the, in our case, it can come to the pancreas also. That is a one hematogenous mode of spread. Coming to the second type of spread, that is a biliary system. Suppose if in case of the hydatid liver disease, intrabiliary rupture is one of the known thing. In such scenario, once it ruptures into the biliary system, it can come to the biliary tract, and from the common duct, it can go back to the pancreatic duct, and from there, it can settle into the pancreatic parenchyma. This is a second mechanism. Other thing is a lymphatic channels, and once you ingest, it can go through the lacteals, it go to the duodenum mucosa, and from there it can go to the pancreas, and that is a third mechanism. Other thing is once it can reach the portal circulation. From the portal circulation, before going into the liver, it can deviate into the SMV or SMV, and from there it can SMV or splenic vein. From there it can settle into the pancreatic parenchyma retrograde spread. These are the fourth method. The last method is the retroperitoneal dissemination. If you observe closely, the intestines, even though small intestine considered as a intraperitoneal organs, and the mesenteric border is not covered by peritoneum. Here you can see mesenteric peritoneum is not covered by peritoneum, and these roots leads to the root of mesentery. This is a pancreas organ. This is a pancreas, which is a retroperitoneal organ. And suppose if the infected forms are in the small intestine, it through the mesenteric border, it can go to the posterior wall of the abdomen. From there, it can reach the pancreas. These are the retroperitoneal dissemination. Other clinical features, not only apart from pancreatic hydatid, can present with various manifestations. In our case, it is presented as a pancreatitis, but it can lead to various manifestations. And first, I'll discuss about how hydatid disease in the pancreas can cause the acute pancreatitis. This is a by the obstruction by the pancreatic duct. It can cause upstream dilation, can induce the pancreatitis. This is one of the clinical case report where you can see within the C loop of the duodenum there is a well-defined cystic lesion. MRCP also revealing the same. That is a cystic lesion, hydatid cystic lesion, causing the upstream dilation of the both biliary and the pancreatic duct. And she had undergone surgery, and here, of course, surgery, you can see the cyst wall of the cyst wall. And another thing is intrabiliary rupture of the hydatid disease can cause leakage of the cystic contents within the pancreatic duct, which can induce the pancreatitis. It's a case report. Here you can see this is a cyst wall, well-defined cyst wall with calcifications, and which is freely communicating into the pancreatic duct. Here you can see the dilated pancreatic duct in the distal body and the tail region, which is freely communicating with the pancreatic, hydatid cyst. Here in the US also, they demonstrated the communication between the pancreatic duct and cystic lesions. Ours is the second case. Another reason is intrabiliary rupture of the hydatid disease lead to the migration of the daughter cyst and the contents into the common duct, and which can cause the upstream dilation of the pancreatic duct. Repeated episodes of the pancreatitis can lead to the chronic pancreatitis. In such case, the secondary to the hydatid disease. This is a one case report. Here you can observe cystic lesion in the pancreatic tail region, and on ERCP, you can notice the dilated and the tortuous duct with stricture formation of the pancreatic duct. Here you can notice, which means the repeated episodes, recurrent episodes, it can cause, it can induce a chronic pancreatitis also. And post-operatively, resected specimen here, the distal pancreas and cystic wall of the cyst wall, and these are the various daughter cysts. Another presentation is it can present with extrabiliary obstruction. Here you can notice the cyst wall in the head of the pancreas can lead to the upstream dilation and intrabiliary radicals dilatation within the liver. And they can present, if it is a large, they can present as a epigastric mass lesion also. And if it is a big enough, and it can compress the surrounding structure and then get from the formation of the fistulization. That is, it can rupture into the biliary tract, or it can rupture into the pancreas, which can, if it rupture into the biliary tract, it can induce acute onset of cholangitis, and it can perforate, it can fistulate or cause perforation into the duodenum also. And these are the various presentation, but it can lead to complications like it can form thrombosis of the surrounding vessels and the left-sided portal hypertension. It can secondarily get infected by the abscess formation. Coming to the differential diagnosis, and we need to consider all cystic neoplasms of the pancreas like IPMN and neuroendocrine tumor or cystadenoma or solid pseudopapillary tumor also. Non-neoplastic pseudocyst comes under ion parts, and other congenital cysts should be considered. These are some example. Here you can see the pancreatic serous cystadenoma. This is IPMN, and this is a solid pseudopapillary tumor. This is a pseudocyst benign thing. These are the congenital pancreatic cysts. Coming to the diagnosis, one first thing to do is serology. Serology has sensitivity of 93% with specificity around 90%. And these are the common methods what we practice. And the imaging wise, ultrasound is the initial imaging, and subsequently to rule out other organs involvement, we may consider CT, MRI, or X-ray depending on the requirement. US, in this case, we use the US to diagnose, confirm, and to demonstrate the fistula. It helped in this case, but even though it is not routinely practiced, yes, US can be considered. Pancreatic hydatid, even though it's rare, this is one of the large case series where they mentioned about 58 patients of varying age group. And pancreatic head region is the most common site, and within the pancreas there was a head region is the most common site involved, and simultaneously extra pancreatic locations involved in a few cases like liver, kidney, lungs. And the serology here you can notice surprisingly only 41% cases it was negative, around 15% only positive. That's why even though negative serology does not exclude the presence of hydatid disease. Suppose if it is a positive, definitely it adds to the diagnosis, but if it is negative, you can't exclude the diagnosis. In this series, they noted complications like fistulization and pancreatitis reported in the six cases, and portal hypertension in the 2 cases. And all patients had undergone surgery. 2 patients died. There was no recurrence. This is one interesting case report. Here you can see the cyst wall in the large well-defined cystic lesion in the pancreatic distal body and the tail region, and which is communicating with the pancreatic duct. Here you can notice the prominent pancreatic duct. Normally, if it is non-dilated, it is difficult to see the pancreatic duct in the CT image. Even though you can see, it is readily seen like this. And this patient had undergone surgery, like a distal pancreatectomy and a splenectomy. And this patient, these are the pancreatic hydatid cyst lesion. This is a spleen, and this is distal part of the pancreas. On the dissection, you can see the multiple daughter cysts within the cystic lesion. And one more thing, this patient here, they by inserting the process, they demonstrated the communication of the pancreatic duct through the cyst wall. If our patient had undergone surgery, she might have had undergone this major surgery like distal pancreatectomy with splenectomy. Coming to the management, and they definitely most of the for this reason, surgery is the ideal treatment. And in few cases, those are surgical high risk patient, we can consider the pay. And endoscopic technique is very rare. This is the first case we treated and managed endoscopically. That girl is relatively, frankly speaking, fortunate because she had communication which is approachable. We could completely clear out the entire pancreatic cyst contents. And irrespective of these modes of treatment like surgery, pair, or endoscopic techniques, medical therapy is mandatory. Generally, we treat with albendazole for 4 cycles. And surgery, if fistula is present, yes, a central pancreatectomy, distal pancreatectomy is the treatment of the choice. Fistula is absent, yes, partial or complete pericystectomy or a omentopexy can be done. A few case reports of percutaneous treatment also reported, but even though it's very rarely practiced. Endoscopic management definitely can be considered when there is a biliary fistulization and cholangitis, and that is a main thing. And this patient for primary pancreatic hydatid, definitely I consider it as a surgery is a main modality of the treatment. This is a relatively separate case, and that girl the fortunate. But if such obvious communication is there, yes, we can. A patient is ready to follow up. Yes, we can attempt. I briefly tell about the other case of the liver hydatid, which has intrabiliary rupture. Here you can see these are the MRCP films showing the dilated intrabiliary ducts with multiple cholangitic abscess. This is a dilated CBD which is containing the various membranes inside the biliary tract. In this also, we did the ERCP, attempted ERCP. We dilated the tract, and after the on extraction, you can see the various large membranes of the hydatid. That is also one important case we managed endoscopically without any requirement of surgery. In this, what was unique in this case was with help of endosonography, we could demonstrate the distless communication with confidence. After that, we tried. With that, she improved. Fortunately, I can say. And even though hydatid is a very rare cause of acute pancreatitis, still in the presence of cystic lesion, we should negotiate this diagnosis. We should consider this hydatid disease in the pancreas also in case of the acute pancreatitis cases, or even chronic also. In the background of the cystic lesion, yes, this is also one of the it comes under one of the differential diagnoses. As is the endemic area, we should keep this possibility in our back of the mind always. And even though negative serology does not exclude the hydatid disease, one more thing is even the endoscopic management is safe alternative to surgery in very very selective cases, I can say. And particularly in the presence of intrabiliary rupture and cholangitis, yes, definitely endoscopic management can be life-saving. Thank you. And I'll briefly cover the other presentation.
Can we just discuss about this case probably and can go to the next presentation, or want to combine both?
Yeah, I'll combine both. This is very brief, sir, 1 to 2 minutes.
Sure.
Okay, sir. We'll discuss this case now, and after that, after some time, I'll start second.
Okay. So, Dr. Ramiredi, this case is very interesting and very nice case actually. It's very rare. We have seen
Yeah.
some hydatid of the liver rupturing into the biliary system. We have seen
Yeah.
occasion, but this is the first time I'm seeing that hydatid which is formed within the pancreatic duct and presenting as a recurrent acute pancreatitis. Is a very quite nice. And very interestingly, I think 3 episodes, on the 4th episode only, the imaging has been done and they picked up as dilated pancreatic duct, isn't it?
Yes, sir.
5th time you've done EUS and further imaging you picked up. And all your presentation, the EUS image of the intrapancreatic very good. For others to discuss. Is it audible?
Yeah, now it is audible.
Yeah.
So we had lost you for some time in between.
Okay. No, your the EUS image was very good. EUS image of the hydatid cyst, which is involving the pancreatic duct with the multiple daughter cysts within. That was very nice, beautiful. And in your presentation, you showed a lot of illustrations along with the animations that are very informative actually to make it others to understand actually. Otherwise, it will be very difficult. How come hydatid come inside the pancreas? So before opening the discussion, just I have one or two questions actually. Like one thing is actually like what is our endpoint of your therapy? Because most of the time in hydatid the chance of recurrence is high. Though we know that this is definitely a very good palliative measure to do ERCP and removing all the daughter cysts. Still, there is a mother cyst which can the chance of recurrence. Though we give medical management, what is your endpoint of therapy, both endoscopically by ERCP or vice medically? So, how long you give management, or what is your endpoint of ERCP? And what happened to you? The second question.
Yeah, sir. This patient, we followed up for. We did two sessions of ERCP, sir. We evacuated almost the entire pancreatic cyst, and we continued medical therapy. And 4 cycles we have given, sir, after 2 weeks duration, 3 weeks duration. 4 cycles we have given. And on follow up of at the end of 1 year also, she is completely symptom free, and cyst also got resolved. That's why I'm telling. Otherwise, she landed up in distal pancreatectomy with major surgery. That's why I'm telling it's a very unique case, and there's no such reports also to substantiate. But she is fortunate, and after 5 years, she's doing.
I think she needs to be on follow up also. There is
Yeah, definitely, sir. Because every time we can't treat with endoscopy. It is a surgery is a main quality of treatment. It is a very unique in this.
Okay. So, anybody else would you like to ask any questions? Like any other audience, anyone from the other unit? Dr. Adish from Bangalore, Dr. Gaurav, if anyone is there or joined or not. There are no questions. Probably we can move to the next presentation.
Dr. Madhavan, I have one question. Because Dr. Ramiredi said specifically that one of his lines was we avoided a surgical intervention and we managed it at our end. So I would like to know what would have been the surgical options for this patient.
She had undergone pancreatectomy, sir. Pancreatectomy, and the distal pancreatectomy with that is the main thing. Distal pancreatectomy. That is the only option.
Okay, so.
Yeah, because she has communication, that is the option, sir. Otherwise, if it is no communication, yes, we can do cystectomy also.
Right. So she would have undergone distal pancreatectomy, which is definitely so.
Major.
I think I'm not sure if your surgeons are too happy with that, but yeah, I agree.
But she's a young girl, 14 years young girl.
Exactly. Yeah. That I was just coming to that. So being so young, I think, it's important to, try to see if we can manage more conservatively. So thanks, Dr. Namadan. This is more for the benefit of all of them to see, what is avoidable to get to the table, unless it is so much so required. Yeah. And you are the best at, so it's a classic example. Yeah. Dr. Madhavan, your comments.
Dr. Rami, did you notice anything like, IPML like picture? Like what was a papilla when you just look at the papilla?
No, sir. No, sir. We send that membranes also for analysis. It is a very classical of hydatid disease. And in IPMN, generally, yes, it is one of the differential we should consider, particularly in the background of cystic lesion and the dilated pancreatic. There is no doubt about it. But in this case, it is very pertinent. We could see that cyst, obviously, cyst coming out of that papilla.
It's like mimicking the fish mouth appearance. That's what I'm asking. It's not very undoubtedly this is a hydatid.
Yeah, definitely we should see IPMN is much more common than the pancreatic hydatid. I can say that.
Any questions from the audience? Can we go to the next presentation? Dr. Ramiredi, you are not audible.
Okay, sir.
Yeah, you are audible.
Yeah, these are the various intragastric balloons available till date. And if you observe closely, this is from balloon from Allurian is the only one which not required endoscopy. But most of the cases, both for placement and for retrieval, 2 times endoscopy is required, except for the balloon in which we can swallow. But for retrieval, endoscopy is required. This is a Allurian balloon is the only one which there is no need for endoscopy. You can, even though it is not for everyone who is overweight and obese, it can be considered, particularly if they are committed to healthy lifestyle changes and they are ready to under regular follow-up and they are willing to participate in the behavioral therapy. Then we can consider in any case of the overweight, not only 30, even more than 25 to 35, those are willing to for the behavioral therapy and the lifestyle changes, yes, you can consider an option. Even though for every patient, we tell the conservative measurements like dieting and physical exercise. If they are not responding to that, this is the one option we can consider. And most of them are not willing for surgery. Then in that scenario, definitely it is a better option. But we can't place this balloon in all cases, particularly those patients with esophageal motility disorders and those underlying intestinal strictures are there and previous surgery, intestinal surgery, we can't consider this case. These are the comes under the contraindication. Those who had undergone surgeries like previous bariatric surgery, gastric and esophageal surgery, laparoscopic band ligation, anti-reflux surgery also we can't consider. And there is a more chance of the bleeding like liver cirrhosis, coagulopathy, those are on anticoagulants also we try to avoid this. And coming to the device placement, it is a very easy. Entire procedure would take around 10 minutes. And this is how balloon looks like. This is a capsule, and with attached catheter, you can see, which is of around 100 centimeters length. This capsule is of only 2 inches length, and it can be swallowable yeah, it is easily, not exactly easily, with patient cooperation, it is swallowing this capsule is not very difficult. Mm, Before placing the capsule and spending the time with patient and explaining the entire procedure one more time, because there will be as there is no anesthesia also, there is no requirement for anesthesia also, they will be anxious. That's why to make them more comfortable, definitely we should explain the device, the device and the procedure. Only thing is we should place the capsule over the back of the tongue, yeah, like this. Sometimes if patient is educated enough and they are, if they can do on their own also, but it is better to place with the help of the physician on the back of the tongue. Once it is inside the back of the tongue, by the time they are ready with the glass of water or carbonated drink, any carbonated drink would be more beneficial, more easy to swallow. Yeah. Simultaneously, once we push the capsule, patient swallows the capsule, and we place the balloon around 30 centimeter. We encourage them to drink more and more water or carbonated water, which facilitate the further passage of the balloon into the stomach. Like this, if the patient with a natural swallowing and esophageal motility only, it will reach the stomach. Only thing we need to confirm at this stage is to confirm the position of the balloon, that capsule. Uh, Before doing the procedure, as per the patient height, we adjust the fluoroscopy. And once after placing the balloon, we again confirm the position of the capsule inside the stomach. Inside the stomach, it will inside the stomach and fluoroscopy and X-ray, it will look like this. Here you can very clearly see the capsule outline and this one radio opaque marker. Once it is below the diaphragm, it curves towards the left side and places in the fundus region. And this entire thing is a air shadow. Once we confirm the position, we started filling the balloon. It is around 550 ml. It would take around 2 to 3 minutes to fill the entire balloon. And patient also started having that fullness and some sort of cold feeling inside the stomach. Once filling is completed, and we withdraw that catheter, and once again we confirm the position. Here you can see the by X-rays. Here you can see the two air shadows. This is a fundus shadow because of the carbonated ring. You can see under diaphragm, some within the stomach. You can see that air bubble, and this is the entire balloon. Here you can see the radio opaque marker. This is a small air bubble within the balloon, intragastric balloon. Once we here it is also same thing. This is a small air pocket within the gastric balloon. This is the entire intragastric balloon. Once we confirm this one, patient, as it is a very delicate procedure, patient can go home. And these common symptoms after placing the balloon are the nausea, vomiting, mild abdominal cramps, and reflux is a very common symptoms. Very uncommonly, we can notice sometimes chest pain and fatigue and constipation also. And the day before placement, we tell them to hydrate well, drink more and more water, and we start a few medications like PPIs and to increase the mainly patient tolerability after placement. And on the day of the placement also, we tell till 2 hours prior to the placement, they can drink the clear liquids, and the antiemetics we start, and they consume. With this placement of the balloon, we can expect around 10 to 15% of the weight loss. And it is a very simple and a decade procedure, with acceptable side effects. And even though it can be considered, particularly those not willing for surgery and the non-responder to any diet and exercise, and they're not willing for any sort of intervention, even endoscopy also. With this, even though it's a it can cause, if patient has complained to diet as per our instruction, yes, we can notice up to 15% of the weight loss. In my experience, my first case within the 2 months, she lost around 13% of weight loss. 13 kgs she lost. She was initially to start with, she was 101 kgs. With after the end of the 2 months, she lost 13 kgs. But she was very compliant to diet. That part we should appreciate. Thank you. Thank you.
Thank you, Ramireddy. It was a nice presentation on a swallowable intragastric balloon. And I think the endobariatric therapy is rapidly evolving. I think next to third space endoscopy, I think everybody is focused on how to manage this obese individuals endoscopically, because most of the patients are not opting either a surgical or a medical therapy. Most of the medical therapies are failed. I think this is a very promising field. I think the balloons and ESG. And,
Yes.
yeah. So how when compared to the other balloons, even by literature, like how do you think that the swallowable balloon is going to, come into the major picture, or still a lot of other balloons are there in the market actually? How do you compare?
It is definitely costlier when compared to other balloons. Only advantage is it can be without anesthesia. You can do it. That is a major advantage. And when compared to what the company people are claiming, is because of its thin wall, that balloon itself, tolerability is and the complaints and the tolerability will be much more. They are claiming it, even though they have to prove it, but they are claiming it. As such, my experience is in the 2 patients, they are tolerating it well. That part. And one more assurance is within, suppose if they if accidentally any leakage from the balloon, and they are replacing it within 3 months. They are getting that within 3 months. That is a advantage with this. Otherwise, if those are not affordable, yes, we can consider other balloons also, maybe with slight more discount.
I think probably in US the endoscopy and sedation cost is double the size of the cost of the balloon probably.
Yeah.
That would be another that they would have brought this idea of swallowable intragastric balloon.
Probably.
Yeah, so because we are using actually the SPATS-3 adjustable balloons. So we don't have any experience with this swallowable intragastric balloon.
It is very easy to perform.
How do you actually when you give a patient, how do you select which patient go for a balloon or EAG? Do you suggest both, and what is your
Sir, definitely after coming this, definitely consideration for the ESG. It is also permanent procedure, ESG also. Definitely those people who can afford, they are opting for it. They want to try it. Suppose if they fail in this, they opt for ESG. For my selection, if it is a 25 or they are more than 25 to 35, definitely both can consider for balloon. Generally, ESG 30 to 35, that range we consider. But still, for them also, it is with ESG also we can expect 15 to 20% of weight loss at the end of the one. It is also comparable. Those who are affordable, yes. Those not affordable with great difficulty, they are accumulating money of around 2-3 lakhs. Then better to go for ESG because it is a procedure and easy to do.
Okay. So, do you have any? The combined team of surgeons, psychologists. And because it's a very, very important that the procedure alone is not going to be helpful.
Yeah. We have a dietitian from dietitian, surgery, and endocrinology, and from our side for things like that. Those particularly if you suspect some eating disorder, definitely we refer them to psychiatrists. Otherwise, we don't generally.
Okay.
Endocrinology, dietitian, surgery, and medical gastro.
Thank you. It was a nice interaction actually. Like any discussions, any questions from the audience? You want to ask any questions?
I have two questions. So one was compared to surgeries where the volume of the stomach is reduced for this swallowable balloon. Once the balloon deflates, the volume of the
Yes.
stomach is back to normal. So how do the
Yes.
patients deal with normal appetite coming back, and how
Yeah.
does it sustain in the long term? And my
that,
second question was, sir, any documented allergic reactions to the material or any other complications?
no, sir. Complications are known. For allergy, sort of thing is raised. Complications like intestinal obstruction because of the partial depletion and the distal migration, and pancreatitis and GI bleed. These GI ulcers. These are the common complications described rather than allergic thing. And so for your first question is regarding size. Yeah, definitely, sir. We clearly that's what, sir. That's what I recommended before going to this procedure. We counsel them. It is a term. It is a very temporary method. Mainly, this 4 month duration, you lose around 10 to 15% of the weight loss. You need to change your eating pattern, behavioral pattern. That is a main treatment. This helps as a one of the transit mode. That is ultimate. Suppose if you go undergo ESG or sleeve gastrectomy, even for I consider bypass also. If you eat more, definitely you will gain that behavior pattern. That is the main thing. We should counsel them. But otherwise, if they eat normally, definitely they'll gain weight. There is no alternative to that. Even you undergo major surgery, you will gain weight if you eat normally or with exercise. You will gain weight. You counsel them only 4 months duration. This is for only 4 months. You lose more weight during initial months. Later, it will be done. After 4 months, you will become normal. We should counsel them very proper. Mainly, we encourage them to change the behavior pattern.
I mean, to add to that, actually, basically, these procedures are all mainly for induced weight loss, basically the intense weight loss phase. Then we have to maintain, as he has mentioned, that along with the diet, some exercise, we have to maintain that weight loss.
Maintain,
And
yes.
and second thing, we have to prevent the weight loss also. That is also another important thing. Just doing the procedure, as he said, actually, it's just not not going to achieve our goal of weight loss, actually. So,
Yeah.
this is
Definitely, that is one of it maybe is definitely it is a very temporary method, and down the line maybe with combination and sequential balloon placement and combination of the medical therapy, they are even though trials are ongoing, they are getting interim analysis, they are getting good results. But still, it is we can consider it as one of the option where patient is not willing to consider for any sort of intervention. Then we can be considered it. If they want to give a try, yes, it should be considered.
any questions? Any other questions from audience? Dr. Harish and Sanat,
Yeah.
can you wind up?
Yes, it doesn't look like there are any more questions. So, if there are no other questions, especially from
There are
DMD
no other
students,
questions. I'd like to thank actually Dr. Rami Reddy for presenting a wonderful case, very interesting and rare case of hydatid of pancreas presenting as a recurrent acute pancreatitis. And he has beautifully managed with the ERCPs and followed by medical therapy, and patient is doing well after 1 year on follow-up. Actually, it's very good. The second presentation also is the novel mode of placement of intragastric balloon, and again, it's going to be a game changer. And we had a nice interactions during both the sessions actually. And with that, I would like to thank Dr. Rami Reddy for presenting cases and as well as for discussing the intragastric balloon. And the audience, I would like to thank for participating till the end of the CME and for a nice interaction. Thank you once again.
Thank you. Thank you, Dr. Rami Reddy. Thank you, Dr. Mahadevan, for such a beautiful presentation. It was very informative. Thank you, Dr. Mahadevan, for moderating the session. And we look forward to more such sessions in the future.